Hello and welcome to the Washington AHEC podcast. My name is Jordan. I'm one of the instructors for the Washington Area Health Education Center Scholars Program. Today I'm joined by Dr. Josila, who is a doctor at University of Washington Medicine, who does a lot of work in patient advocacy and care. Hello, Dr. Josila. Welcome to the podcast.
Hi, Jordan. Thank you so much for having me.
So would you just take a moment to introduce yourself, the kind of work that you do, what your experience is?
Yeah, happy to do that. So I primarily work at Harborview Medical Center, which is an affiliated hospital and clinic system with UW Medicine, University of Washington Medical. It is also funded in part by the King County. And so it acts as a hospital safety net. And playing that role, we're very fortunate to have Harborview in that its mission is to care for people that have historically had more difficulty in accessing healthcare. So that might include people who are uninsured or underinsured, have difficulty with finances related to healthcare access. Might include people who have other structural barriers or systemic barriers to health in general. So maybe that's addiction, related to substances, mental health concerns, or housing instability. And then lastly, one of the main mission populations for Harborview Medical Center is people that don't speak English or have limited English proficiency because they historically have had a harder time accessing care. And so I work in two primary care clinics at Harborview Medical Center. I work in what's called the downtown programs. So that's the Pioneer Square Clinic. And so I work there 2 days per week, and then I spend the other 2 days per week in the main hospital in a clinic called the International Medicine Clinic, where I see immigrants who have limited English proficiency that have come to the United States through various pathways, be that refugee resettlement, a very formal pathway. Maybe they've come to the United States seeking asylum, and are still going through that process. And so through these various clinics, I see a pretty diverse patient group. And I'm very lucky to have this role.
Wow, that's awesome. It sounds like you have quite the array of experience as well as getting to work in an exciting situation. Here at AHEC, our focus is on working on healthcare workforce in rural and urban underserved communities, under-resourced communities. And we like to encourage our AHEC scholars when they graduate from their healthcare programs to consider working within those communities. So this sounds like this will be a great conversation to talk about, to share with our AHEC scholars. So I know when we were preparing for this podcast, typically I jump right into some questions, but it sounds like maybe the best way to frame our conversation today about working with population who have limited English proficiency is actually with a case study. So I'll pass it off to you to explain the case study and how that's going to frame our conversation for today.
Yeah, definitely, Jordan. I really like to start with a case because it frames the things that you might be thinking about when you're trying to care for someone with limited English proficiency, because it goes beyond just the language. There's actually a lot more to it. And so the case I'm going to just briefly present, I won't go into great detail, is based on a real patient encounter, someone I've seen in clinic, but I've altered some key details to provide anonymity. So imagine that you're seeing a 30-year-old man. He comes into clinic to discuss back pain. This is your first time meeting him. If you're going into the healthcare field, be that medical school, nursing school, whatever healthcare field you're going into, back pain is like one of the most common things you'll see. I was just traveling over the Thanksgiving holiday and had some long flights, and today I have some back pain. So, we all go through it. It's all around us. So this gentleman, 30 years old, he's Somali speaking. And so we go into the room and I connect an interpreter to help us via a speakerphone. And I proceed with gathering a history. There's a typical framework by which we gain a history, and I go through that to understand the nature of his pain. As we proceed with our visit, though, we kind of go down another tangent, and he starts to share with me other concerning symptoms, feelings of stress and difficulty sleeping, depressed mood. And as we shift our focus to these issues, which he relates to his pain, he shares with me some of his recent history. This includes working as a journalist in Ethiopia and significant torture by the Ethiopian army, leading to separation from his family, culminating in arrival in the United States to seek asylum. And so we started with back pain, one of the most common problems we see in the healthcare system. And now here we are talking about significant trauma and all of it kind of interconnected. And as we're having this discussion and I'm connecting with him and eliciting this history, always present with us is a third party, the telephone interpreter, someone that's not in the room. We can't even see their face, but they're the go-between, communicating details, communicating the questions that I'm asking and the details he's providing me, but then also communicating emotions and empathy and trying to build a relationship. And so a lot of nuances there that I hope we can dive into as we talk today.
Yeah, that's a great case study to talk about. I imagine I'm not a healthcare provider myself, but I imagine, there's a tendency to want to just like dive in. What's the problem? Here's a solution to focus on. Learning that patient background and history and trying to take a more holistic approach. In the whole meantime, having to have that third party presence of an interpreter and how complex that situation would be to work with that. So I think this will frame our discussion quite well for today. Maybe at the end we'll come back around to how did that turn out in the end. So in the meantime, if someone wanted to learn about caring for patients with limited English proficiency, where would be a good place to start?
Yeah, great question, Jordan. So I think the first thing that I would say is that there's such a great need. I mean, the need for healthcare is kind of ubiquitous. We see it in all patient groups, but particularly in people with limited English proficiency or people who are kind of unfamiliar with the United States and how the healthcare system works. There's an even greater need. And so if you're not encountering it, it's because you're not looking for it or you're avoiding it. And I think a lot of that comes with kind of it's an uncomfortable territory. It can feel daunting to dive into it. And so I would say, first of all, don't be afraid. Go out there and do the work and be curious. Learn from the people you're seeing and put yourself in situations that feel challenging to you. Because I think what you'll quickly realize is that the people that you're taking care of are happy to teach you, happy for you to learn with them about cultural competence, about being curious about different languages and cultural practices in relation to health. That can actually be the impetus for a beautiful provider-patient relationship. And I've seen that myself. I've experienced that myself. And so that's the first thing that I would say. You all are here as AHEC scholars, and so I think you're already having these motivations to be serving these communities, and so I think you will certainly do this. In terms of other resources to support you in this journey, learn from your interpreters. So as you're having these interactions and having people join you, take a minute or 2 minutes at the end of your encounter to ask the interpreter, like, how did that go? Do you feel like I was a good communicator? Do you feel like I was communicating things clearly to you, that the patient was understanding? Get some feedback because you'll quickly learn that there are some best practices. There are some ways in which to communicate via an interpreter that reduce the risk for errors in interpretation and also that allow for us to communicate some of these more complicated things like emotions and empathy. And then lastly, there are a number of resources that can be really helpful. I do want to point you to a website that's run out of Harborview. It's ethnomed.org. And that website is publicly available to everyone. And it started at Harborview, I think more than 10 years ago. And basically, the reason why it was created was to provide healthcare providers with some language and cultural background to help them prepare for and process patient encounters that they're seeing. It goes into kind of the nitty-gritty about specific disease states, but then also provides general background about different cultures and things that might be relevant when you're building a relationship and talking to that person.
Yeah, that was a lot of really good information. I appreciate that point you bring about like interacting with the interpreter because in best case scenario is like if you were going to give a discourse in front of a group of people through an interpreter, they would have the script ahead of time, but in a clinic setting, there's just no way, it's no possible. So they're doing quite a bit of heavy lifting themselves, and so having that debrief moment with them for sure would be a great use of that resource. I guess my first follow-up question to that would be, even in instances where a patient might speak maybe like a limited or semi-proficient amount of English, is it still a good idea to make use of an interpreter who speaks their primary language even in that instance?
Jordan, that's a great question. And this is something that we run into all the time. And so, I would say that ultimately it comes down to the patient's preference. And so, in a non-judgmental way, with no strings attached, asking the patient, what language do you prefer to receive care in? And, one would hope that they would choose the language that they are most fluent in. But that's not always the case because there are a lot of perceptions around interpretation. Patients have fears regarding confidentiality. Some of these communities that we interact with are relatively close-knit. And so this fear that like, oh, I'm going to share something with maybe a fellow community member that's sensitive. And do I want to do that? I have this doctor here who I know doesn't know the people around me, but who is this person on the phone that I can't see that is listening in? There's a fear there. And then some of the other things that come with the healthcare system in general, hidden costs being a big one. People having this fear like, oh, like I'm asking for this additional service. Am I going to go home and then a month later in the mail receive a huge bill? The answer is no. It's mandated by federal law that interpretation needs to be provided free of charge to patients. Anyways, so going back to your initial question, even people who are semi-proficient in English, ideally they're communicating in the language they're most comfortable with because you really want to get, healthcare and when you're talking to people about their health, you really want to get kind of the pure essence of what they're experiencing because
Yeah.
already it's kind of hard to know.
Mhm.
Already it requires kind of this curiosity and questioning and interrogation. And so if they're having to censor their language to use vocabulary that's simpler or vocabulary that they know, you're going to end up uh, losing some of the details that might be important.
I was thinking that myself, like when I go to the doctor, I don't catch 100% of everything they say, and I often will speak the, native English speaker with the doctor, so that's really important. So you kind of touched on it a little bit, but maybe more pointedly, like, is there something that the providers can do themselves to help their patients who have limited English proficiency to learn how to better navigate the healthcare system or have better outcomes in their care?
Yeah, so that's a great question. There's a number of models for this, actually. I think most simply thinking about personal responsibility. So, like the AHEC scholars in their future practice, thinking about what can they do themselves. I tend to do a bit of like an orientation when I'm first meeting someone to say, this is why we're doing this. This is why I prefer to use an interpreter in communicating with you. This is why I prefer for it to be a professional interpreter, not like a friend or family member who is accompanying you to the appointment. And I really try to frame it as something that's in the best interest of the patient because it really is. It helps me to know what's going on. It helps to eliminate bias. There's so many benefits. And interpretation is not simply translation. There's a distinction between those two things. Translation, you're just kind of word for word shifting to a different language. But interpretation, the interpreter is doing a complex task when they're listening to you and understanding what you as the provider are saying in English, and then converting that to kind of an equivalent thought or idea in a different language, which a lot of times is not word for word, depending on some of the cultural aspects, the person's perceptions of care. And so,
Yeah.
yeah, trying to kind of impress that upon the person when I first meet them. Because once you lay the groundwork, then it just sets you up for success. And it not only sets you up for success, it sets that patient up for success in every subsequent encounter with whichever other provider that they are seeing.
Yeah.
Um, interprofessionalism is key here because it's not only one person's responsibility.
Mhm.
Thinking about the patient's first interaction with the healthcare system. Maybe they walk into the clinic and they're interacting with the receptionist, the person who's checking them in for their appointment, gathering their insurance information, like being a good model and saying like, hey, I want to speak to you in your native language. I want to get an interpreter here to support you, to make sure that you have the opportunity to ask all the questions you have. And then subsequently each encounter there forward modeling this good behavior in terms of using a professional interpreter.
I
Perfect.
really appreciate that point about how like interpreting is not just word for word translation. I had the privilege of learning Spanish within a community in my early adult life, and I was studying to be a counselor for a little bit, and one of my professors made the point like you might have like proficiency me as the future provider in Spanish, but that might not be the best case for you to work with Spanish speaking patients. Like there's still cultural things that I might not understand that would be better served by somebody who is more native of a speaker of that language. So something that I've come across myself in the health, in a context of providing care. So I can imagine it's important when you really care about best outcomes for the patient that you always approach them with what they need.
I mentioned that there's different models to this. And so there's like the personal
Mm-hmm.
responsibility aspect, like the things that we can do when we're interacting with someone. But then like the system itself can create best practices for this work. And so telephone interpreters, video interpreters, these are available. And sometimes you might prefer to use like a video interpreter where you have someone on the screen that the patient can interact with. And then sometimes you might actually want to have someone there in person with you, have an
Mm,
interpreter in the room with
sure.
you that you can physically interact with. The patient can as well. There's an increased level of trust there when
Mm,
they're part of the visit. Harborview Medical Center is they're kind of at the forefront of this. They have a really robust interpreter services department. There are a number of other institutions across the country that are similar. But one thing they do really well is they actually have an interpreter, kind of a crew of interpreters that do more than just interpretation. It's a program called Community House Calls. And so these are interpreters that one of the prerequisites is that they're heavily involved in their communities. And so they go to health fairs, they go to community centers and work on health education, and then also see people in the hospital and provide them with interpretation. And then beyond that, they have a panel of patients that they see very closely that they interpret for regularly. So for example, if they're assigned one patient, they're present with that patient at every visit they have, whether they're seeing their primary care doctor, whether they are going to physical therapy, whether they are having surgery and seeing a surgeon. There's a bit of continuity there, and that helps the patient feel more comfortable with the health system, having that trusted third party there.
Well, that's pretty incredible. It's like that person almost becomes a member of their care team in a way because they're following them to all the appointments across the spectrum. Um, there's a lot of good stuff to parse out there. I'm trying to figure out which direction I want to go next. How about, are there any, so because you're talking about some of these resources that exist, we work with students, like I mentioned, rural communities, urban under-resourced communities. Are there some differences? I'm sure that like resources are going to be a big thing that differs between those two different settings, but how does it change for working with interpreter services if you're in a rural community versus if you're in a more urban center like Harborview?
So this is a big issue, and it stems from the reality, which is that provision of interpreter services is an unfunded mandate. So it's mandated by the federal government that people who don't speak English well, or it's not their preferred language, should have access to an interpreter. And yet, that's not at all connected to our healthcare reimbursement. So, insurance
Mm-hmm.
companies do not pay for interpretation. This is something that the institution that you're working for, whether that's a clinic or a hospital system, they need to take it on themselves and fund it. And they're required to, but sometimes it can, just the reality of privatized healthcare, there's going to be variability in the implementation. Um,
Okay.
it depends on how much of a priority it is for the health system administrators. And and so yes, you'll see tons of variability even within urban centers, you'll see tons of variability. Then moving from urban to rural settings, you'll see tons of variability. I
Okay.
think, as AHEC scholars, one thing I would suggest to you is to try to get a diversity of experience to see how this practice happens in different places. Because ultimately, there's only two advocates for this group of the patient themselves can advocate for interpretation services. It tends to not happen because all of our patient surveys that are sent out are primarily in English. So how are people going to
Mm-hmm.
provide feedback, right? And so the next advocate is you as the provider saying, hey, I'm having a hard time caring for these people for this person because I can't communicate with them effectively. I get onto the interpretation phone and I spend 20 minutes trying to connect with someone and they can't get me the language that I'm looking for. And here I am just wasting my time when instead I could be providing this person with care. And so don't be afraid to to highlight the issues that you're encountering and saying, in order to provide care for this person, I really need this. And I've worked in other places where this is the standard of care. So when you get that diversity of experience in your practice, then you can be a better advocate for change and hopefully have a system that works for you.
That's it's great that you mentioned that. In fact, one of our other modules for this year is about advocacy and how to get involved in that. So if a student's hearing this and they think this is something they're passionate about, this would be an opportunity for sure. I know we don't like to like say what are some easy solutions, but are there some like really maybe not easy, but low hanging fruit solutions that we could approach that would help bridge that gap in healthcare?
Yeah, like I can give you some examples. A lot of interpretation just comes down to the logistics of it. And so, you know, most healthcare systems, they have at least a phone interpreter company that they contract with. Clinics, hospitals,
Mm,
they all have this. The ones that are more invested in funding this type of work will have an in-person interpreter cohort. They'll have video interpreters as well. But say that we're just thinking about the basic, which is having access to a phone interpreter. There's ways to make it very useful. I actually mostly use phone interpreters in my practice. You have to have a good speakerphone.
mm.
It needs to have good audio quality and needs to be able to get pretty loud in case people have hearing loss. It needs to be able to pick up the sounds within the room. We have like these nice speakerphones that have multi-directional mics that work very well, as opposed to like the speakerphone that's part of a normal headset
Yeah.
that doesn't work well.
Yeah.
And then the other things are kind of just the the way that you navigate the room. And so making sure that the speakerphone is between you and the patient so that it's picking up what both people are saying and it doesn't feel kind of awkward or cumbersome to use it. So these are definitely really low-hanging fruit, does not have to be complicated. Other things are just like the systems things that I mentioned. So like having processes where you're proactively asking someone, what is the language you prefer to receive care in? And making sure that that's identified early on so that you're setting the stage for success moving forward. I think with those two things, like good microphone and speakerphone system and kind of the system that identifies a language, you should be set up for success. And it doesn't have to be super expensive or hard to access.
Yeah, I appreciate that. Those are very practical, well within reach of somebody to be able to implement those solutions. That's great. So kind of related to, you're talking about phone and making sure that those are, you have the best speakerphone and system available. Are there any technologies that you're excited about that are helping to kind of bridge the gap in You mentioned a lot of it's telehealth, so is there some like video conferencing that's becoming more popular or other ways to engage with interpreting services?
Yeah. So technology these days is very exciting. Whether it's going to pan out and be reliable, that's the big question. And so I'm sure many of you might be aware of kind of the translation services that are now easily accessible, like integrated into your phone, where like you can be on a phone call with someone and they're speaking in a different language and it's translating it in real time to English. These technologies exist, and the reliability of them, the accuracy at which they're translating is not validated. So that's, I think, a big gap. AI is becoming pervasive in healthcare. We have AI tools that listen into a visit and write a note. The AI tool at UW Medicine that's currently being used, it can I might be misremembering the exact number, but I think it can understand up to 27 languages and create a transcript in English and use that to document in the medical record. But again, these are not validated tools. And so I think that for me, I think the tried and true, like a person on the other end of a phone who can take in the context, not just translate, but interpret and listen for the cues that might signal that the patient is confused, because there are verbal cues. I think that that's still the best way. And some of the technology that we're coming up against is all very exciting, but still imperfect. So we'll just have
Yeah.
to see how the landscape shifts over the coming years. One of my fears is that in the absence of regulation, that funding for in-person interpreters or video and telephonic interpreters might be cut or shifted towards artificial intelligence or some of these other tools. That would be, I think, a real disservice because the personal aspect is really crucial, I think.
Mm.
But we'll have to see how the landscape shifts.
I appreciate you bringing that out. I know that we like to think about technological solutions solving all of our problems, but when it comes to something as personal and high stakes as working with people's health, it feels like there's still some things that a human touch is definitely the way to go. So one of the things we talk about quite a bit in AHEC Scholars, related to some of the stuff you're just talking about as well, is stigma and bias and being aware of those things, not only within ourselves, but noticing how they show up in the medical system as well. So can you speak a little bit to that about where you most often see stigma and bias showing up?
Yeah, and I think all the AHEC scholars will experience this, but we're under certain pressures in the healthcare field, primarily funding pressures, time pressures, and this shows up not only in interpretation language, this shows up in in many ways. You can imagine busy emergency department, someone comes in with kind of classic symptoms. It sounds like they might have the flu or a cold, and the provider that's seeing them has a board of people in the waiting room, and the person kind of speaks some English, and they just fumble by with some broken English, ask some basic questions, and say, "You probably have a virus," do these things. You can imagine that situation. Very easy to imagine. And yet, that can be a huge disservice to someone. Just the fact that they don't have the opportunity to feel comfortable in their communication, possibly withholding information. And so I think that a lot of the bias and stigma related to limited English proficiency really just comes from the system that we're forced to work within because of those pressures that the system is dealing with. It's difficult to separate language from some of the other things that are at the center of US politics these days, immigration being the big one. deservingness of healthcare is something that we're often told what people deserve. We're told that, this person is going to be unable to afford healthcare because they're not a citizen, despite them having a serious illness, despite them having no money. It can be really challenging to push back against that. I'm a firm believer, that healthcare is a human right and that financial barriers or immigration status should not prevent someone from being healthy. And yet on a personal level, there's only so much we can do. And so that can be really defeating and can be exhausting to push back on. And eventually, you might just start to accept the status quo as it is. And, by stigma, I'm not sure necessarily the right words, more so just kind of, I don't know what the right word is for that, but just being forced into practicing in a way that is less than ideal and starting to accept that is the norm. And so that happens all the time. And really, I'm hopeful that you'll learn some skills in your advocacy portion of this course to start to unpack those things as you notice them in your practice. But I think at its core, the main thing that we can all do on a personal level is to just constantly remind ourselves that the people we're taking care of, regardless of what they're dealing with, regardless of kind of the factors that are complicating their care, their access to healthcare, they're all human, and trying to just bring ourselves back to that and separate from all of the noise that we have in the news and in politics to provide someone with the best thing you can in that moment.
That's really tough. It's almost like the stigma and bias from people who are making decisions results in you being hamstrung in the level of care that you're able to give. One of the other units we've done for AHEC scholars talks about like if you can be that pause, maybe a person who's in the healthcare system has had several negative experiences. If you can play your small part and just be in one positive experience that they've had, that can go a long ways to restoring trust and confidence that person can seek the help and care that they need.
Yeah, definitely agree with that.
Well, we're running up on our time, and I want to be mindful. Really much appreciate the discussion today. One last question before we get back to our case study. For yourself, we were just talking about somewhat a heavy of a topic and how disheartening that can be. But what do you enjoy about your work? What excites you? Like, what gets you out of bed in the morning that makes you want to come to work and prevail, regardless of what the situation might be?
No, thank you for that question, Jordan, because that's really at the root of it. Finding the joys and the things that we do. I do love my work. I love hearing people's stories. I love connecting with them and learning from them. And I find that when I see people with diverse experiences, I have even more to learn. And it challenges me in ways that are unexpected. And I really appreciate that. There's something just really satisfying seeing someone with limited English proficiency in clinic and kind of breaking down that barrier with the use of an interpreter and connecting with them. It's something that I think maybe part of it is that, they don't get that all the time in other sectors, whether they're like shopping at the grocery store or getting in a taxi. Like we do have this mandate to provide interpretation. That's kind of a luxury. It's nice. It's the right thing, but I feel really lucky that I can have a conversation with someone about their health, but then also about, tell me about what life was like for you when you were growing up. Tell me about your journey to the United States and what that was like. I get this little treat to be able to learn from them and connect with them, all the while using an interpreter. And so I really treasure those stories that I hear, and the relationship feels even that much sweeter. I think because, honestly, a lot of the people that are here with limited English proficiency, not all of them, but a lot of them experience some level of social isolation.
Yeah, I can imagine it really would be fulfilling to be that positive touching point for somebody who's had maybe not the best of experiences or even just compounding the joy of helping somebody out when in need and being able to provide those services for them where they otherwise might not have been able to access them. So speaking of, you said you love people's stories. Let's hear the end of how did this work out with your patient. So just to recap, a 30-year-old Somalian man who came in presenting with back pain. You used an interpreting service with them to get more of their history, and you found out that they actually had some significant trauma they experienced in their homeland before coming to the United States. So how did that work out? What was the eventuality working with that patient?
Yeah, yeah. Thank you for bringing us back to the case. So, fortunately, the federal government has a grant program that specifically helps survivors of torture navigate the healthcare system. Something that's so important because what they need is multifaceted. It's not just seeing a primary care doctor, it's navigation, it's mental health care. And so identifying that he was a survivor of torture, and had these horrific experiences that are now manifesting as various symptoms, we were able to connect him with a case manager that's funded by the Survivors of Torture grant. And that case manager was subsequently able to connect him with mental health care, and that's ongoing. But I think it all started with kind of building that trusting relationship in the beginning with the use of an interpreter, kind of starting to unpack some of the context surrounding his back pain and creating that safe environment. And so I think next time you all are seeing someone with limited English proficiency, I think as a first step, when we were talking about this before, I was telling you to not be afraid, just be curious, try it out, and learn from it. Just think about the environment you're creating when you're using the interpreter. Think about the questions you're asking, because I think the tendency is for it to turn into an interrogation and to say like, "Oh, you have back pain. When did it start?
Mm,
Is it spreading anywhere else? Are there any associated symptoms? What makes it better? What makes it worse?" Because those are kind of the easy questions to ask with an interpreter. You ask
mm,
them, the interpreter asks them. But to ask the questions that are emotionally charged, like, tell me about your life prior to coming to the United States. What are you feeling right now? How are you feeling? What's stressful to you? These open-ended questions that can feel really complicated, both for you to say, for the interpreter to interpret, for the patient to respond to, and then for you to receive. Challenge yourself to be more empathic in eliciting those things and creating that safe space.
yeah, I think that's really important. I can imagine related to what we are talking about, some of the systemic issues, the pace of a healthcare setting is probably not conducive to stopping and really sitting with a patient. So it does require intentionality and focus. But as we're learning from your experience, it pays dividends to take that time and work with patients like that.
Those skills will be carried with you in everything that you do.
Mm.
It won't only be the care of people with limited English proficiency, it'll be in every encounter you have. It'll shift something in your mind to start to do that more. Really core skills of a clinician.
Well, thank you again so much, Dr. Josula. That was a fantastic discussion. Thank you so much for your time and your experience and your expertise. I'm sure our students will benefit greatly from hearing your experiences.
Thank you for moderating, Jordan, and for listening to me for some time.